there's a couple of things that I took away from the ERA 223 presentation that I think are really key. Number one is that we probably haven't discussed and paid enough attention with patients about the risk of fractures associated with all of our therapies, including drugs like abiraterone and enzalutamide. And we see that in the control arm of ERA 223, we saw an 11% fracture rate associated with abiraterone. That had never been reported like that before. Certainly wasn't collected like that in Cougar 302, essentially the same population. So it's clearly telling me that this study uncovered something because it was looking for fractures at a higher rate than we'd seen before. And although many of those are asymptomatic fractures, it still matters to me because asymptomatic fractures could lead to more symptomatic fractures down the road. The second takeaway from ERA 223 was that bone strengthening agents made a big difference in the outcomes of these patients. And it really suggests that as we're thinking about the evolution of these patients, even in their hormone-dependent states, hormone-sensitive prostate cancer states, non-metastatic disease states, we want to be thinking about conditioning bone for strength. And there's a couple of ways to do that. Calcium and vitamin D are great supplements that every one of our patients should be on from the beginning of hormonal therapy. Exercise is a key way to manage that, particularly in our patients that are not heavy and bearing a lot of weight at baseline. It's really important for them to do, weight-bearing exercises. And then the third is using bone strengthening agents to help prevent osteopenia, because these are not necessarily pathologic fractures. These are fractures that can happen anywhere in bone. And then we know that this is a population of patients that are not going to get just ADT, but drugs like abiraterone and others, and in many cases for years, and that these kinds of complications can happen in those scenarios at a higher rate than we appreciated before. I think the third thing with ERA is that radium can add to that complication, and we didn't know that from Alsimpica because we treated it a more advanced disease population. We didn't look carefully by scans, and these were patients in the control arm that had 1 year to live. So fractures were less critical to a patient population that was dying of disease complications in a short time frame. As we think about using this drug earlier, it's more important to be aware of this complication and to be able to mitigate it, which the bone strengthening agents certainly help. They don't make it go away completely, and I think it is something we need to be including in our conversations with patients. But it shouldn't deter us from the fact that we want to keep these patients alive as possible, as long as possible. And for that overall survival benefit, radium is unique in class. There's nothing else in our armamentarium like radium. So if we don't use it, we're going to lose that survival benefit associated with it. So finding out how to use it safely with the minimum amount of complications associated with it is key. And I think bone strengthening agents really help us do that, along with these other lifestyle changes and monitor. Look, there's a lot of differences between the US and Europe. We don't have to go into these. Culturally, my jackets are much looser fitting than theirs. But at the end of the day, there are differences because there's differences in how we view the relationships between healthcare systems and physicians. In the US, we value the physician-patient relationship as being the ultimate arbiter of how we should manage these folks. In Europe, it's a little more paternalistic, and it's a little bit more health system driven. And that may be cost effective and wise on a national level, but in the US, we value the opportunity to be able to individualize our treatment choices. And I think that's really important. I think the label that we have in the US is really reflective of the ERA 223 data. It was studied in a situation where we're not really using radium, the upfront use of abiraterone and radium 223. And it gives us a warning regarding that usage. And I think that's important because we don't want to have off-label uses or uses that are outside of our clinical experiences and clinical data. But what it doesn't do is it doesn't undermine the Alsimpica data, which demonstrated a benefit associated with radium, including best supportive care, which included anti-androgens, ketoconazole, and external beam radiation. And we know that layering those therapies in addition to radium in the Alsimpica study was associated with a survival benefit, better than those therapies alone. And we want to continue to offer our patients the best survival benefits we can. And we'll want to monitor for these complications, which may have been underappreciated in that context in the future.